As part of our perfusion concept, we have the exemplar of stroke. Stroke is the third leading cause of death and disability in North America. The highest incidence occurs in people over 65 years of age, but that does not preclude it from occurring in children as well. Risk factors for the development of stroke include hypertension, heart disease, diabetes, sleep apnea, hyperlipidemia, and that looks like it's spelled incorrectly, smoking, and sickle cell disease. And the list continues on the other column. Substance abuse, living in the stroke belt. And what I mean by that is that there's a large swath of people that live in the southern states that tend to be predisposed to having strokes. And I believe that is mostly due to diet and things like hypertension and diabetes and hyperlipidemia, because they have a tendency to have that good old southern cooking, that country cooking with fried foods and gravy. So that seems to be associated with a higher incidence of stroke as well. And then there is family history, and certainly obesity and sedentary lifestyle. But other things can also put you at increased risk for stroke, including certain viral and bacterial infections. And if they've had a previous TIA or transient ischemic attack, then they are more at risk of having a stroke. In fact, I do caution patients that come into the emergency room with signs and symptoms of stroke. And when they are diagnosed as having a TIA, we'll learn more about that, but when they have this transient ischemic attack that resolves on its own, it's important to let them know that that's a warning sign for them. So they need to know how to proceed if they have these symptoms again, because they are at much higher risk of then having a stroke after that. Risk factors specific to women include oral contraceptive use, pregnancy, childbirth, menopause, migraine headaches accompanied with an aura, autoimmune disorders, and also clotting disorders, also called coagulopathies. So women, especially in these groups here, they are at a higher risk of stroke. Let's now talk about the pathophysiology of stroke. A stroke is sometimes called a cerebral vascular accident, or CVA, or even called a brain attack. And a stroke is a condition in which neurologic deficits result from a sudden decrease in blood flow to a localized area of the brain. And therefore, you can see why we are discussing this under the concept of perfusion. A sudden decrease in blood flow to a localized area of the brain. Now, we can also say that strokes can be either ischemic or hemorrhagic. Typically, we'll say that 80% of strokes are classified as ischemic strokes, and 20% are classified as hemorrhagic stroke. When blood flow to and oxygenation of the cerebral neurons are decreased or interrupted, pathophysiological changes at the cellular level take place in 4 to 5 minutes. Severe or prolonged ischemia leads to cellular death. Strokes lead to loss or impairment of sensory motor functions on the side of the body opposite the side of the brain that the damage it occurs. And this is known as contralateral deficits. Okay, So once again, a contralateral deficit is the loss or impairment of sensory motor function on the side of the body opposite the side of the brain that's damaged. Okay. And in the picture, we see those two major classifications of stroke, including on the left side here, when you're viewing the slide, we see a hemorrhagic stroke when the blood vessel ruptures within the brain. And so now we have free blood on cerebral tissue. And that is toxic to the brain tissue. Okay, it's very, it's an irritant to have free blood on tissue. Very much an irritant. And so we will obviously prefer if the blood stays within the blood vessels so that it can reach its destination and to the, it can travel to the tissues distal to that are dependent on it for perfusion and oxygenation. And then we also have that ischemic stroke shown over here. And it's the result of a thrombotic occlusion. Okay, so this embolus is traveling until it gets stuck in the narrow lumen of a vessel. And we should say specifically the vessel is a cerebral artery. That means all the tissue distal to it is not being perfused and not receiving oxygen. So ischemia eventually leads to necrosis, and there we have the deficits appear. These next two slides simply want to illustrate that contralateral deficits that occur. In the first slide here, we have a left-sided stroke or a left CVA. And this patient had a left injury to the brain, and so therefore you see in the picture that we have resulting on the opposite side a weakness. Okay, so we have the right side has hemiplegia, meaning that there is some paralysis and weakness here. Other things that can occur are listed in terms of what type of deficits you observe when somebody has a left stroke, CVA on the left side. Including in that, we'll see impaired comprehension. So they're trying to remind you here, because obviously 2 + 2 is not 5, so that means that their comprehension is impaired. There are other things that are very characteristic of injury in this area. And here, where the injury has occurred on the right side of the brain, we have a right stroke, right CVA. That means everything, the deficits will appear on the contralateral side, on the patient's left side. That's where we would observe for any paralysis or weakness. Hemiplegia means a weak paralysis on this side of the body, this half of the body. And we'll talk about those definitions later, but hemiparesis, on the other hand, would be weakness. So there could be weakness or paralysis on the opposite side. Also, with injury on the right side of the brain, we see these type of deficits that occur. Spatial perceptual deficits, short attention span, impaired judgment. They become very impulsive. Okay, so they're just trying to show you that depending on the location of the stroke is where we would where we should be assessing and looking to see where the deficits are. Now, let's talk a little bit more about this ischemic stroke. After all, we said about 80% of strokes are of the ischemic type, which means that they're caused by the interruption of blood flow to the brain due to a clot, a blood clot. The buildup of plaque, fatty materials, calcium, and scar tissue is involved in most ischemic strokes, narrowing the arteries that supply blood to the brain and they interfere with or block the flow of blood. Of course, we recognize that narrowing as atherosclerosis. So an ischemic stroke can be either thrombotic or embolic. I'm going to go back and start at the top of this slide, because at the very top we talk about a TIA. We said earlier TIA stands for transient ischemic attack, and it is a brief period of localized cerebral ischemia, and that causes neurological deficits lasting for less than 24 hours. So in that first blank, I would want you to write less than 24 hours. TIAs are often warning signals of an ischemic thrombotic stroke. So that's the other thing I'd like you to remember about that and put it in the blank there. These TIAs are often warning signals. Generally, these patients will go home with simply an aspirin, because again, remember, aspirin is going to prevent platelet aggregation, and this perhaps can facilitate perfusion through those narrowed cerebral arteries. But we don't put them on anything stronger at this point, because it does resolve and the patient is not left with any deficits. So that's also another important thing to remember with the TIAs, that the deficits resolve within those 24 hours. Okay, there's no residual deficits. Okay, now let's talk about a little more about that thrombotic stroke. They're caused by a blood clot that forms in an artery directly leading to the brain. Embolic strokes occur when a clot develops somewhere else in the body and travels through the bloodstream to the brain. An embolic stroke occurs when a blood clot or clump of matter that's traveling through the cerebral blood vessels becomes lodged in a vessel that's too narrow to permit further movement. Now, embolic strokes, because of the pathophysiology and how they occur, we're going to see the signs and symptoms have a sudden onset. So embolic strokes have a sudden onset, and in the other blank you could put causes immediate deficits. Okay? But the thrombotic stroke, remember, is caused by the blood clot that is forming in the artery. So because of that, the onset is more gradual. With those thrombotic strokes, they usually evolve over 1 to 2 days, and they tend to progress slowly. And that is not the case with embolic strokes. As we said, they have a sudden onset and immediate results. Most strokes are ischemic strokes, as we've just talked about them, and they result from conditions like atherosclerosis, atrial fibrillation. There's many things that can lead to an ischemic stroke, but let's talk a little bit more about atrial fibrillation, because we have already learned about that in the previous unit. Remember, we said that there's no problem living with atrial fibrillation, but if you are living with it, what's important is that you are anticoagulated so that you do not form clots. Sometimes patients, even when they are anticoagulated, still can have issues with forming clots. I don't want you to misunderstand me, but we will address anticoagulation to prevent the formation of clots. But sometimes, if they're not anticoagulated properly, they can still throw a clot. And if that clot it becomes dislodged and starts to travel, it is now an embolus. An embolic stroke can result as it travels north into the brain, leading to a stroke, and then we should see changes in the immediate responses and changes in the patient in terms of the deficits that we can see. Other things as well. We've studied endocarditis. How about that one? When we talked about the vegetation growing on the heart valves, and that those vegetations can break off and travel and become an embolus as well. This too can lead to a stroke. There are many things that can lead to an ischemic stroke, even reduced blood flow. Imagine if you don't get enough blood flowing to the brain, then yes, there are going to be localized areas that are not perfused. And so this can be also a reason for having a stroke. Now, when a very large ischemic stroke can occur in one of our carotid arteries. Remember, that's the largest artery in the neck, and it can close off if there's a large ischemic stroke. The artery can become occluded by a few different mechanisms, including things like blockage from a traveling blood clot. Also from atherosclerosis, a focal atherosclerosis, which truly is the most common cause. But surgery can be performed emergently on this artery if the area of occlusion is in the neck. So what they have come up with is this device that you see in the picture. It's called the Mercy Retriever. It allows a thin wire to become embedded, or like a corkscrew, into a blood clot and then pulled out of an artery. And this device was approved for this purpose in 2004. So we do have some options for treating even emergent needs for patients. Emergently, we can go in, and this is an endovascular procedure, you see. We insert this catheter and this device all the way up through the vasculature to the blood clot in the carotid artery. Okay, and in this picture you see the fibrin clot in yellow that they are trying to remove. As we said, only about 20% of strokes are hemorrhagic. A hemorrhagic stroke, or intracranial hemorrhage, which it's sometimes called, occurs when a cerebral blood vessel ruptures. These strokes occur most often in people who have sustained increase in blood pressure. They occur suddenly, often when the affected person is engaged in activity. They are caused by uncontrolled bleeding in the brain. This bleeding interrupts normal blood flow in the brain, and by flooding the brain, it kills brain cells. There are two main types of hemorrhagic stroke. The first type is a subarachnoid hemorrhage, and it's uncontrolled bleeding on the surface of the brain, in that area between the brain and the skull. Another type is called an intracerebral hemorrhage, and that occurs when an artery deep within the brain ruptures. Both types of hemorrhage can be caused by structural problems with the blood vessels in the brain. In a stroke, the blood entering the brain compresses adjacent tissues and causes vessel spasm and cerebral edema. Blood irritates the meninges and brain tissue, which causes an inflammatory response. Onset of manifestations is rapid. The most common manifestation of stroke is weakness that involves the face and arm, and sometimes the leg. Other common manifestations include numbness on one side, loss of vision, speech difficulties, sudden severe headache, and difficulties with balance, and others that you may see listed here as well. Notice this CAT scan. We have a normal CAT scan on the left, and then an intracerebral hemorrhage on the right. Blood shows up as white on CAT scans, so it's very easy for us to see or visualize that there is an intracerebral hemorrhage here. Remember that this is going to compress as this mass grows. It's going to compress the adjacent tissues and cause all kinds of swelling, inflammation, and edema, and the vessels to spasm. This slide talks about some of the most common manifestations or signs and symptoms of stroke. And the picture here shows you, as this gentleman went to pick up a carton of milk, there was weakness there that caused him to drop the milk carton. So the most common symptom is weakness that involves the face and arm. Other common manifestations we've just talked about, and they're listed here for you. But and this happens, and it's part of our neuro assessment with all of our patients, especially if they go in for surgery, and before they went in, their baseline, so to speak, was alert and oriented, and there's no problem. But then when they come out of a surgery and now they are confused or they're slurring their speech, that's a big warning flag that the patient may have had a stroke during a surgery, okay? Especially if the surgery is done on his carotid arteries. Okay, you have to acknowledge that there could be some risk there if they do a procedure to remove plaque from inside a carotid artery, that a piece of that could become dislodged and travel as an embolus and result in changes in that patient, including speech difficulties. Well, there's a lot of sensory perceptual deficits that are associated with stroke as well. And we're going to talk about each of these. Hemianopia is a big one that they like to test on in nursing. And actually, it's often referred to, as we see down here in the slide, homonymous hemianopia. Okay, that's a very big word. But what we see in this, the only thing that I really want you to pay attention to on this slide is this one here at the bottom, because we're talking about hemianopia. Hemianopia means that you only have only half of your visual field is working. Okay, you only see one half of your visual field. But if you add this word homonymous to it, it means that the same half of the visual field of each eye is affected. Okay, so it looks like this when a patient has this deficit, where half of their field of vision on both eyes is affected. And as you can imagine, this causes a considerable disability, because the result is that the patient begins to ignore one side of their body. So they need to be constantly reminded to remember that they have another part of their body, because they can't see it. And so they can also bump into things. They don't see obstacles on the affected side. And they're likely to have real problems like using stairs or getting out of doors, crossing roads, things like that. Okay, so homonymous hemianopia is a condition in which the optic nerve pathway is damaged in the brain, and the same half of the visual field of each eye is affected. If the damage occurs to the right side of the brain, and that's not what we're seeing here, that's the opposite of what's in the slide, what I'm saying. But if the damage occurs to the right side of the brain because of a stroke or tumor, both eyes lose the left half of their visual field. Okay, so we can extrapolate to this diagram. This person had damage occurred to the left side of the brain, and because of a stroke, then the right side or right half of both eyes is that's the word I'm looking for, damaged, or is is not affected. That's the word I was looking for, affected. Okay. So let's move on to now another term, a sensory perceptual deficit, meaning that the patient can be left with this type of problem after a stroke. Agnosia refers to inability to identify objects. Okay, agnosia, unable to identify objects. Apraxia, unable to speak because of voluntary movements are impaired. Okay, and certainly neglect syndrome, and that's where they ignore one half of their body. They don't even realize that it's there, and they constantly need to be reminded of about one half of part of their body. They need to remember that half of their body needs to be washed, has to be dressed, etc. Okay. And this is just giving you a glimpse into this phenomenon called homonymous hemianopia. Okay, so on the left we see that this is a normal vision for somebody who has can adequately see both sides of their vision field. But when somebody has hemianopia, one half of their vision field is not is affected. Okay. Please read in your textbook, and I hope your current textbook has information about this. But the way we treat patients who have homonymous hemianopia varies depending where they are in their recovery. Certainly immediately after this kind of injury to the optic nerve, you're not going to put things that they need out of their field of vision, right? For example, if you're going to leave a water in their room, you're going to want to put it where they can see it, knowing that they have this deficit. But later on, it's different. During rehab, they need to train this patient to scan the room. Okay, so at that point, it's okay to put the object in the area that is impaired, that they can't see, because you're training them to scan the room by placing it outside of their field of vision. Okay, so if you need more clarity on that, turn to your textbook and make sure you do understand that. Okay, other signs and symptoms of stroke. A change in consciousness that ranges from mild confusion all the way to a coma. And that's a very common sign of a stroke. And then we have behavior changes, including emotional lability. That means their emotions go up and down very quickly. They might be crying one minute and then laughing the next. Okay, they have the whole range going up and down. There's no stableness, there's no stability there. It's labile. They have a loss of self-control, a decrease for tolerance and for being able to tolerate stressful situations. They can even have intellectual changes, including memory loss, decreased attention span, poor judgment, as we've seen earlier, and an inability to think abstractly. Okay, so you have to be very concrete with them and give them short, direct commands, basically. Signs and symptoms of stroke include disorders of communication. They can have slurred or inappropriate words, or they could be mute, not able to speak at all. Okay, so we have all different ranges of impaired communication. And then we have motor deficits. Here, I wrote down the definitions so you can make sure you don't get confused between the terms hemiplegia and hemiparesis. Hemiplegia is paralysis on one side of the body, and hemiparesis is weakness on one side of the body. And then, of course, we can have other motor deficits, which are flaccidity and spasticity. So we talked about that before. And also they can have elimination changes, okay, as a result of stroke. Remember, we said some of the most common symptoms that somebody's having a stroke is the fact that they have weakness in the face and arms. Well, if there's weakness in the facial muscles, what you're going to see is a facial droop. So we assess for that by looking at the patient when they are smiling. Okay? Normal is to have both sides of the face move equally. Abnormal would be having one side of the face that doesn't move at all, and then you see the picture here that's represented on the slide. Okay. Then we also have, for determining arm weakness, we assess for arm drift. We'll have the patient put they can also be, usually they are, on a stretcher. Okay? Typically they'll come in through the emergency room, but of course this can happen to patients on the floor as well. If you are working in a hospital that is a stroke center, then the ambulances, the EMS, will be instructed to bring the stroke victim to your hospital, and the nurses there will be trained in how to assess for stroke. And one of the assessments includes arm drift. They usually are laying on a stretcher, not flat, but sitting up so that they can, we can try to assess for arm drift. But they put their arms out in front of them, as you see here, at an equal level. You start out equal, and then you ask the patient to hold their arms out straight for 10 seconds. And then you observe for 10 seconds and see if one of them begins to drift or go slowly downward. Okay? If both arms move equally or not at all, then that's normal. What's abnormal is when one arm drifts compared to the other. Okay? We have something very equivalent to that as well, and that's called leg drift. And in that case, we only ask them to raise their legs for 5 seconds. You can even do one leg at a time to see if they can hold the leg for 5 seconds, and then see if there's any difference between the two sides, indicating weakness. The 3 treatment stages of stroke are stroke prevention, acute care immediately after a stroke, and rehabilitation after a stroke. The treatments used in management of stroke include surgery and rehab. Rehab includes physical therapy, occupational therapy, and speech therapy. Nursing care of clients experiencing stroke is often complex and multidimensional, and requires consideration of continuity of care for clients in acute care settings, long-term care settings, rehabilitation centers, and at home. We see on the right side a young boy. He had a stroke. Although it's not as common to have children with strokes, it certainly does occur, as we'll see later when we study some type of congenital vessel abnormalities that occur in children. And so this boy is in rehab, and he's trying to improve his motor skills, both his fine and gross motor skills that were severely limited, as you can see on his right side. And his rehab regimen includes lots of exercises, positive reinforcement, encouragement, and confidence in them. That they're going to, and they need to have that can-do attitude, because that's going to give them a positive impact. It's going to have a very positive impact on their training program. Okay. Okay, we need to now talk about diagnosis when our patient comes in with signs and symptoms of stroke. And we see in this picture here, there's a yellow arrow pointing to the whitened area again. So you need to understand that the whitened area reveals a stroke in this patient. This is an MRI. So this looks different than the CAT scan. This patient presented with dizziness and nausea. And when they did the MRI of the brain, it revealed a right cerebellar vascular stroke. Okay. It was the posterior inferior cerebellar artery that was involved in this stroke. I think it's pretty easy to recognize this lobe of the brain, or this area of the brain called the cerebellum. So as you can imagine, with a stroke in this area, that this individual is going to have difficulty with coordination and balance, and he presented as being dizzy. Okay, another big point to mention is that when they are considering if a patient has had a stroke, they may order a lumbar puncture. Okay. Diagnosis is achieved with diagnostic imaging, but also lumbar puncture if there is no increase in intracranial pressure. Okay, that's a big if, because you're going to see different things in the literature. I want you to understand that you can do a lumbar puncture. It is truly the exception. Okay. Many times in nursing texts, you will see that it says never perform a lumbar puncture on a patient with a stroke, for example. And that the reason they're saying that is because that the patient may have increased intracranial pressure. And lumbar puncture in the presence of increased intracranial pressure may cause uncal herniation. Certainly you wouldn't want to cause the patient's brain to leave his skull, correct? No, we wouldn't want to do that. But the exception is this, that you can do a lumbar puncture if you're using it therapeutically to reduce intracranial pressures. Okay? So it fortunately is not our decision to make as nurses. But we don't have to freak out, because the physician will determine that. Because if we do a lumbar puncture and remove CSF from that area, that's going to make more room in the vault, okay, in our cranial vault. And that will bring down pressures. So if the patient has increased intracranial pressures, we can use lumbar puncture to reduce those pressures, to remove the CSF in a therapeutic intervention. However, there is a risk when you do a lumbar puncture in the presence of increased intracranial pressure. You could cause an uncal herniation. All right? Now let's move on and talk about that other very important tool for diagnosing and monitoring the evolution of a stroke, and that is called the NIH stroke scale. That's the National Institute of Health stroke scale. Sometimes it's the NIHSS. You'll see that as well. Um, so let's look at the next slide, because here you see a picture of a table that talks about the 11 elements that we're going to assess in a patient who's having a stroke. Okay. And through this neurological assessment of a patient who's experiencing an acute stroke, it's really critical that we accurately diagnose them, that we treat them and care for them throughout their hospitalization. So that's why we have these guidelines for the early management of patients with ischemic stroke. And remember, 80% of strokes are ischemic. So this is very commonly used in the hospital, especially in the emergency rooms. And it details the goals associated with early care, including observation for changes in patient condition that might prompt initiation of interventions aimed at improving the outcome after a stroke. So consistent use of a standardized assessment tool, the NIH stroke scale, designed for stroke patients, assists in the achievement of these goals to improve outcomes. The NIHSS is a well-validated, reliable scoring system for use specifically with stroke patients. It consists of 11 elements that reflect the wakefulness, vision, and motor, sensory, and language function of stroke patients. You can access this URL here for a little digital printout, or you can print it out of the NIH stroke scale if you want to look at it more closely. But also you see here that in general, what it indicates when you come up with the score. A minor stroke is 0 to 4. A severe stroke is between 21 and 42. Okay, so it's much more severe of a stroke as the numbers go up in your use of the stroke scale. This is not uncommon at all for especially emergency room nurses to have to do the stroke scale with a patient. And then, of course, when the patient's having a stroke, the neurologist is called. The neurologist comes to the emergency room, speaks to the nurse, say, what did you get on your NIH stroke scale? And then may proceed to give further orders that I would like you to repeat that every 15 minutes for the next whatever. And you have to then do that so that they can see how the stroke is evolving. Is it evolving, continuing to grow and get worse, or is it resolving? We'll see that with the changes in the score to the scale. Okay, so I just picked out a couple items on the scale to look at, because these are words that you'll need to learn about. Item number 9 on the NIH stroke scale is all about aphasia. Okay, and we assess the patient's ability by asking them to describe what's happening in the attached picture. And in particular, I'm talking about the picture on the far left of our slide, where children are climbing on a stool and the mother is washing dishes and the sink is overflowing. And so we have them look at the picture and describe what's happening. Also, we ask them things like name the items on the list there, like you see the glove, the key, the chair, the cactus, feather, things like that. We ask them if they can name those items. And we also ask them maybe to read the list of sentences that you see there. You know how, down to earth, things like that. So we have them do these various these various commands that we ask them to do, and then we score them. And that will give us an idea about how they are doing in that area. And item 10 is dysarthria. Remember what we said dysarthria was. It all is about speech, and we have them do things like read or repeat words from the attached list. For example, say 50-50, say huckleberry, baseball player. Can you say baseball player? So we ask them to repeat words, and then we score them on their ability to clearly articulate those words. Okay. Now, moving on to nursing diagnoses. Okay, clearly, because we're studying the concept of perfusion, this is an example of ineffective tissue perfusion, and the type is cerebral. We can have impaired physical mobility, certainly with the hemiparesis and hemiplegia that results. So there could be impaired physical mobility, and that can in itself result in self-care deficits. Or another example, of course, would be homonymous hemianopia, and neglect syndrome may lead to self-care deficits. They could end up with aphasia, so the impaired verbal communication, and even urinary elimination issues can be impaired. Remember, when there is hemiparesis, there's weakness of muscles. That includes all of the muscles in our body, including the smooth muscles that line our GI tract, for example. There is also the risk for constipation as a result of those muscles being weak. And this is a big one, so I put a picture here to remind you. Impaired swallowing. This is a topic that nursing likes to ask questions about, okay, because it's all about safety. Now remember the word dysphagia. That's the medical term for difficulty swallowing. And due to brain damage caused by a stroke, eating and drinking may become difficult. And that's because of the nerves and the muscles that we use for chewing and swallowing are weakened, especially in the early stages of just having had a stroke. So this may cause the person to choke on food or drink, and having it get stuck in their throat. It can cause them to aspirate as well. Sometimes people also find it hard to keep food in their mouth due to the weakness around their lips. And that can also be quite embarrassing for the person. But the real issue that they would like to test you on is the safety aspect, because we have this great risk of aspiration when they have impaired swallowing. We do not want them to get an aspiration pneumonia because they have a stroke. So typically we don't, especially in the emergency room initially, we do not give the patient anything to eat or drink. And I've been caught in that situation where the wife would ask for her husband, oh, can he have something to drink? And I'm like, no, he can't. You know, I'm not trying to be mean, but I understand that no, we cannot give him anything to drink right now. Likely he's going to aspirate anyway. So we don't really, once a patient has been diagnosed with having a stroke and has been admitted to the hospital, we're not going to want to give them anything by mouth until they go to their swallow study and confirm that indeed they can swallow without aspirating. You see here that the goals of stroke care all begin with the word rapid, and that's because time is of essence here. We need rapid recognition, okay? We need rapid response and reaction. We have to have a rapid EMS system to transport them to the emergency room. These EMTs will call ahead and notify the hospital that they are bringing a potential stroke victim. Okay, so there's that pre-notification. We get that message loud and clear, and then everybody in the hospital is alerted to the fact that somebody suspected of having a stroke is on their way. Time is of essence. We need to diagnose them rapidly, and that means that CAT scan is alerted, and as soon as the patient gets there, they're pretty much gone before the nurse can even do anything that she's wanting to do. So they rush off to CAT scan, and they come back quickly as well. But of course, everybody's trying to do their part as fast as possible so that we can treat them appropriately. So one reason why there is such a rush for a CAT scan, first of all, we know CAT scans don't take long at all. So this is wonderful. We can zip them in and out, and then it's going to show us if there's any white on that CAT scan. That's what it's going to show us, because if there's white there, that means it's a hemorrhagic stroke. Okay? And that gets treated differently than an ischemic stroke. So that is the first thing we have to find out. Is the patient bleeding in his brain, or is it an ischemic stroke where there is a blockage? Because we're going to treat those two completely differently. Brain is of essence because what they're going to announce overhead is that there is a BRAT alert. The BRAT alert stands for a brain attack. Remember how we talked about STEMIs as being an alert for a heart attack? Well, now the brain is under attack, so everyone needs to be alerted. Pharmacy, CAT scan, nursing, everybody, to make sure that this gets treated and diagnosed very quickly. Because brain is dying, and then there's more death and disability as a result of that. So we are very aware of how precious time is when it comes to diagnosing a stroke. So if we give medications, we call them a clot buster medications, that can be very effective if given within the first 3 hours after having had a stroke. Okay, we're talking here about an ischemic stroke, because if there's a clot occluding a cerebral artery, then we need to dissolve that clot to return perfusion to the brain. So it is important that we administer our clot buster within that 3-hour window. There has been shown with studies that there's a substantial benefit from the careful use of intravenous TPA, which is tissue plasminogen activator, in patients with acute ischemic stroke of less than 3 hours in duration. And these therapeutic strategies designed to restore cerebral perfusion in a timely fashion have the potential to limit the cellular, biochemical, and metabolic consequences of cerebral ischemia that ultimately lead to irreversible brain injury. Now, TPA is one such clot buster, as I like to call them. Others include things like streptokinase or even urokinase. These are other examples of clot busters that can be used in these patients. Now, TPA is only good for, I think it was 12 hours after it's made in the pharmacy. So pharmacy will bring it to the emergency room, and it will be kept until and if it is needed. Okay, but it is one of those things where we have to notify pharmacy ahead of time and also radiology ahead of time so that we can get all of this done in a reasonable time frame. With this whole clot buster, keeping that in mind that we may need to do that to save brain from injury. Okay, that of course is not going to be what we use if it is a hemorrhagic stroke. Okay, so that is not how we treat hemorrhagic strokes. All right. Oh, I just want to mention, because there have been more recent studies. So although the original studies really put emphasis on that 3-hour window, more recent studies have indicated that there is still benefit to administering TPA after those 3 hours. Okay, so if you get the history from the patient, sometimes it's like the spouse will say, well, we were watching I Love Lucy when he had these symptoms. What time does I Love Lucy come on? Oh, so it's been 3.5 hours? Okay, that doesn't mean that he's automatically eliminated from receiving TPA, because there are still benefits that can be achieved when we administer it. Sometimes they say even within 5 hours, we can still see significant benefits that would be important for that patient to receive it. But there are contraindications, so let me mention this. When you give clot busters, the nurse is responsible for seeing if the patient has any contraindications and notifying the physician. For example, does the patient have a history of recent surgery? If they went to surgery 4 weeks ago, then they're not going to be a candidate for TPA, because it's going to cause the surgical scar to start bleeding. It will dissolve that clot that was forming from the surgery. And other types of issues with increased risk of bleeding would be contraindicated for this patient to receive a clot buster. Now let's discuss some of the medications associated with stroke patients. First, we'll talk about our antiplatelet agents, such as aspirin. Clopidogrel is Plavix. And the next one there is Persantine, and then the last one is Ticlid. Those are other names. Their generic names are on the slide. But aspirin, Plavix, Persantine, and Ticlid are often used to treat clients with TIAs, or if they've had a previous stroke. Okay. So if a patient came to the emergency room and was sent home because they just had a TIA and it has resolved, they have no deficits, they may be prescribed aspirin, an antiplatelet agent. Anticoagulant therapy with Coumadin, heparin, and Lovenox is often ordered for an ischemic stroke. Okay, so that makes sense because we want to prevent clots in the body from getting larger or from new clots forming. And then we have our clot busters, which are our thrombolytic agents, such as TPA, but I also gave you a couple others like streptokinase or urokinase. Other medications that could be used for a stroke patient, certainly antihypertensives, because it is very common for patients who are hypertensive to be non-compliant, so to speak. I don't like to label people like that, but for various reasons, they don't take their antihypertensives. And we talked about high blood pressure and the fact that it is a silent killer, because you can't feel when you have high blood pressure. Generally, they don't have symptoms. So typically the patients who get a hemorrhagic stroke are those that didn't know they had hypertension, or they knew it and they weren't taking their medication properly. I personally know of one person in a hair salon who was trying to cut corners financially and was just taking her antihypertensives every other month. And then, of course, she ended up with a hemorrhagic stroke, and she couldn't cut hair anymore after that. So it's very important that we also we will be using antihypertensives when they come in with a hemorrhagic stroke, because we don't want their blood pressure to be too high. When they are bleeding in the brain, that's going to just be more bleeding occurring as a result of that high blood pressure. So there will be a use of antihypertensives to regulate that patient's blood pressure so that it's not too high, causing more bleeding, but not too low to prevent the brain from being perfused. So there will be an ideal blood pressure that they're looking for in managing those hemorrhagic stroke patients. Then we also have corticosteroids, certainly for the inflammation, because of the inflammation that occurs in the brain with strokes. And we're going to learn about those hyperosmolar solutions. I hope we'll have a slide devoted to that. I'm afraid we might not, so I'm going to say it here. Another name for hyperosmolar solution is mannitol. So know about mannitol and how it works. It is administered intravenously, and it increases the osmolarity of the blood, and that pulls fluid from the cerebral tissues into the intravascular space, decreasing swelling and edema, and also decreasing intracranial pressures. Okay, so that's very important that you understand mannitol, sometimes also called osmetrol. Those are examples of hyperosmolar solutions. And make sure you use those three terms interchangeably and understand how they work to bring down cerebral edema. Diuretics can be used as well. Certainly once you're pulling fluid off of the brain into the intravascular space, then we would like to have it ridded from the body as it goes through the kidneys. So diuretics can be used as well. And remember how caustic free blood is to the brain tissue. That can cause seizures to occur. So anticonvulsants are also used to prevent our patients from having seizures if they are having seizures. Maybe sometimes to prevent them, but also certainly if they are already having seizures, they would need to be on an anticonvulsant. So this is that surgery that I wanted to talk about in more detail for stroke prevention. We talked about the anterior circulation to the brain. It is the internal carotids. The carotids branch, and it's not uncommon to have atherosclerosis, plaque buildup in this area of bifurcation. Our patients, especially as they age, may have increased accumulation of plaque in that area, and that will occlude blood flow. They may be dizzy because they're not getting enough perfusion to the brain, and they may have other signs and symptoms, different changes as a result of that poor perfusion to the brain. Sometimes they'll need to go in and do this surgery called the carotid endarterectomy. It is abbreviated as a capital CEA, stands for carotid endarterectomy, and you will read about this in your patient's histories quite commonly. And they go in and cut open the carotid artery and pull out the plaque. Now, it's not that uncommon for a piece of that plaque to break off, and it could conceivably go to the brain and cause a stroke. So after the surgery, if the patient comes out with slurred speech and that's not how he went in, then we have to assume that he may have had a stroke during surgery. Okay. Another big concern with this, here on the right side, you see an actual carotid in the bifurcation area, and they will cut that open and remove the plaque. Another big problem is because remember we studied that at the bifurcation that there are baroreceptors there, and now we're going in with instrumentation and manipulating that area. that's going to really mess up the baroreceptors, meaning that our blood pressure is going to be very labile after this surgery. Um, After this surgery, these patients typically go to the ICU for 24 hours because we have to monitor their blood pressure very closely. They can uh, do very poorly very quickly if we aren't careful. Okay, so we need to monitor them very closely, and also we wouldn't want them to have a stroke as a result of this surgery. Now, your viewing assignment for stroke is a TED YouTube video called My Stroke of Insight by Jill Bolte Taylor. It's about 20 minutes, and she's a neurologist, or she might be a neurosurgeon. I'm not sure, but I believe she's a neurologist, and she'll start out showing you an actual holding the central nervous system, a brain and spinal cord. And she was so interested in studying neurology, and she had told herself, I guess, that wouldn't it be cool if she could experience a stroke so she would know what her patients are feeling. And lo and behold, she did have a stroke. And her whole experience about it and her years of rehab, I think she had like anywhere between 7 and 9 years of rehab here to get to this point, but she's able to tell you what she experienced while she was having a stroke. And it really is beneficial to see so that you can understand all those sensory perceptual changes that are occurring in a patient who is undergoing a stroke.